Hi, I am Stephanie Katsaros. I am the Micromolecular Laboratory Supervisor here at Butler Memorial Hospital. And today we're going to be talking about enhancing sepsis care in the emergency department with the T2 bacteria panel. I've been at this hospital for about 2 years, and when I showed up, they were in a process of updating our sepsis protocol, and I was happy to join the team and give my insight and support. A little bit about our hospital. We're about a 300-bed hospital with 200 plus employees. We've won a couple of awards. But what's important is that we're about 80% outreach. So even if we only have about 300 beds, 80% of our work that we do in our lab is from outpatient centers, nursing homes, doctors' offices. We do a lot of work here. We do about 6 million tests per year. So we're a very busy, up-to-date lab that uses automation at every turn that we can. Sepsis challenges. So I believe that this is a little bit broad and kind of encompasses healthcare in and of itself and not necessarily just our challenges. There's challenges in detection. The ability to identify sooner leads to a reduction in length of stay, mortality, and sepsis costs. We have staffing issues. It's difficult to get samples drawn in a timely manner, but also to find appropriate instrumentation that doesn't require a lot of hands-on time and is easy to utilize. Another big thing that a lot of places focus on is the overprescribing of antibiotics. So patients getting prescribed broad spectrum antibiotics in the ED, once they're on a more targeted therapy, not only is it more beneficial to them as a person, but also to the system in that you're saving money and targeting the therapy for, what they're actually trying to accomplish. Where we started was improving our testing menu. So in the need for faster detection and identification, our current tests were, standard, lactic acid, procalcitonin, but, those are necessary, but they're just not as accurate or fast as some of the things that are coming out today. It was also important for us to contain cost and to have appropriate utilization of new tests. So the two things that we did, we brought in the T2 biosystem panels to reduce the identification times. And then we also started using an indice on our CBC machine that's called the monocyte distribution risk. So it's an indice that is an indicator of severe infection and sepsis. But it's part of the CBC. So there's no cost added. It's just an indice that's turned off or turned on, but it requires you to have the Beckman line DXH 900 in order to utilize this test. That's the only instrument that's FDA approved for it. Monocyte distribution width. So what's really cool is monocytes are one of your white blood cells. They're the first cell that becomes reactive when you come in contact with a pathogen. So whether it's bacteria, virus, or fungi, once it starts eating the pathogen, it spreads out and becomes a little bit more bubbly. And what this instrument does is measures that width. So as it eats, it spreads out, the width gets further, and the higher the width, the more likely you have some sort of infection going on, be it bacteria, virus, or fungi. Your body's fighting something. And what's great about the monocyte distribution width is it's not a bone marrow response. So it's going to be raised before your white blood cell count. T2 biosystems. So this is direct detection of species from whole blood in 3 to 5 hours. Your blood cultures are the gold standard. This does not get rid of your blood cultures. This is on top of and in tandem with blood cultures. And what's really cool is you use a purple top and it goes from whole blood. And in 3 to 5 hours, you actually have a speciated target-specific results that tell you, yes, this person has Staph aureus in their blood. So it's a really cool technology. This is the panels. So we carry both the Candida panels and the bacteria panels. We primarily use the bacteria panels. T2 uses magnetic resonance to identify their organisms, which is really unique in that it's not interfered with antibiotics. So it doesn't matter if the patient was on antibiotics or not. Whereas in a blood culture, it may not grow if the organism is sick. here, if it's present, it finds it. So this is about 77% of all sepsis cases are one of these 5 organisms. And so that covers a lot of what you're going to see coming through with sepsis. So it's really, really unique. It's really cool. And it gives you a lot of information pretty quickly. If it's negative, you still have your blood cultures because you pull them at the same time. You have your blood cultures to back up anything that wouldn't be on this panel. But if it's positive, you know they have Pseudomonas aeruginosus in their blood. So it's a very unique test that's very easy to utilize. In order to utilize it, we created an algorithm using both of those tests. So if the MDW is above 20, and you have an abnormal white blood cell count, so that's above 10 or below 4, it triggers our lab to run the T2 biosystems. The way that we were able to do this is by adding a T2 hold tube to every set of blood cultures that's collected in our ED. And all that is just a regular purple top filled. So when they pull blood cultures, they pull a purple top and we hold it just in case the patient qualifies for a T2. This gets the results faster to the physician, and it kind of whittles down the patients that are more likely to have sepsis. So it works really well in our environment to utilize these tests appropriately. Each test takes about 3 to 5 hours. We achieve this 4.25-hour turnaround time by spacing our specimens about 30 minutes apart. So if you'll notice in the previous one, there's only 7 bays on the T2 biosystems, which means that because it shares internal components, if you load all 7 bays at one time, it slows every test down substantially. So if you space them about 30 minutes apart with loading, we're able to achieve that 4.25 turnaround time. We also collect blood on every blood culture that's drawn in the ED. We get the T2 hold tubes for each patient. And we continually educate our ED staff, our ED nurses, and our phlebotomy staff to ensure that they're correctly filling these tubes. It requires 3 mLs at minimum to run, but 4 mLs is ideal. And so we constantly educate them about filling the tubes to the top. I also have daily communications with our infection control staff to make sure that there aren't patients that were missed. Say CBC was drawn at 8 a.m. and then 4 hours later, they decided to draw blood cultures. They're not going to qualify for a T2 when their T2 tube shows up. But if it's a patient that does qualify, we try to catch these patients and get them started as soon as we can. Panel coverage. So this kind of gives you an idea of what we've seen since we started utilizing these tests. There are only 3 Candida positives, and a little bit of that has to do with our patient population. So we have a very aged patient population. We see a lot of sepsis. I've run over 700 panels by now, but it's at about a 15% positivity rate. This kind of gives you an idea of what we're seeing as patients are coming in. And these are a lot of really good numbers. Patients that would have had to wait for their blood cultures to draw or to come positive that we knew within hours had sepsis. So here's our patient case studies. This is really exciting. I'll give you a little bit about our ED. So in order to get our patients through our emergency department faster, as they are admitted or come through, they're assigned a rainbow draw based on their symptoms. So if a patient comes in with chest pain or flank pain or altered mental status, their rainbow draw is designated off of their symptoms. And before they sit down with a physician, they have that drawn, sent to the lab, and resulted in order to better utilize the time of the physician with the patient. So our draws happen as soon as they are checked into the emergency department, and their draws are based off of their symptoms. So our first patient is a 67-year-old male. He came in with altered mental status. He instantly for our T2 because his white blood cell count was 24.7 and his MDW was 23.98. So his procalcitonin is 4.25, which is pretty high. They were thinking sepsis for sure, but altered mental status is one of those that gets blood cultures drawn with their rainbow. So we had the T2, we got it started. He had Pseudomonas aeruginosa in his blood, and we knew that 37 hours before his blood culture gram stain was ready to be read. So 37 hours later, they knew it was gram-negative rods, but we knew that it was Pseudomonas aeruginosus, and so they were able to put him on a targeted therapy to help with that, knowing that sepsis was a possibility. Our next patient is a 70-year-old male. He presented with shortness of breath, and he qualified also. So he got his WBC was 23.2, and his MDW was 23.05. But as you can see, his lactic acid and his procalcitonin are not necessarily super high. So they may not have been thinking of sepsis because he presented with shortness of breath. But we had the T2 tube. We got it started. It was Enterococcus faecium, and that was 20 hours before his gram stain was ready to be read on a positive blood culture. So 20 hours saved, antibiotics adjusted. This patient did well because we were able to catch his sepsis pretty quickly. This is a really interesting case. So this is a 57-year-old female. She came in with altered mental status, which meant that her blood cultures were drawn with her initial rainbow. She has qualified. Her white blood cell count is 21.9 and her MDW is 21.55, but she's flu A positive. So even though her procalcitonin is a little high, they weren't thinking sepsis because she has this flu A positive. They didn't put her on any sepsis protocol, but because she qualified and we had the T2 tube, we went ahead and run it, and she was positive for Staph aureus. So 14 hours before her blood cultures came positive, not only did we let them know that she indeed has sepsis, it was a co-infection with flu A that might have been missed had they not had this test to let them know not only is she septic, but it's Staph aureus, and they could get her on the right targeted therapy to get her out of here faster. This one's my favorite. So this is a 70-year-old male. He came in with chest pain. They did not draw blood cultures. So they looked at all of his labs and they said, you're not having a cardiac event. And they ended up sending him home. If you look at his white blood cell count, it's 11.3 and his MDW is 22.07. So he qualified for a T2, but we didn't have a T2 tube to run on him. And they sent him home. The next day, he came back about 12 hours later. Now he has altered mental status. So when he came in, he qualified for a T2. His white blood cell count and his MDW have both gone up substantially. And even though his procalcitonin isn't high, we suspected sepsis in the lab, and we got the T2 started, and it's Staph aureus. So what I did, because I recognized the patient, I pulled his CBC from the day prior just to see if, had we been thinking sepsis, would we have caught this a day earlier? And it was positive for Staph aureus also. So his initial visit with chest pain was likely sepsis, and we could have caught it 24 hours earlier, and maybe he wouldn't have left and come back. So, and it's still 24 hours prior to the gram stain being ready to be read. So this is a really interesting case in that had we known, we could have gotten him started earlier and not had him leave. Positive outcomes. So this is improvement of care. It's improvement of length of stay. And we know that sepsis is considerably longer with length of stay. So ID has been switching antibiotics as soon as these T2 results come out to put them on a more appropriate treatment course. And the ID perspective, it's a helpful algorithm using two tests that provide supporting criteria to run the T2 test. So you're not overutilizing these tests, and you're more targeting the patients that are more likely to have sepsis. And what we're trying to do is reduce bounce back patients like the last patient. Had we known when he came in the first time, had they been thinking sepsis when he came in the first time, maybe they wouldn't have let him leave. Maybe we could have caught it a day earlier. So our next steps. What we've learned through all of this is that T2 is not only an incredible test that is capable of doing a lot, it's something that we want to utilize better and continue to utilize with blood culture draws. So we're working on adjusting the qualifications for T2, maybe including more patients. But we're also looking at bringing T2 to our sister hospitals within the new merger that we just went through. One of the things that we consistently do is educate and re-educate our supporting staff with staff turnover and people coming and going. It's a constant battle with making sure that they understand the test, what the results mean, and also to fill the tubes completely in order to get the results that they're looking for.